Hello, Insta fam. It's Dr. T here on a Tuesday night. I hope you guys are all really well. I am back. I'm back. Well, I was back last week, wasn't I? Wow, whirlwind trip. Hope you guys are good. I hope you had a lovely long weekend. Or if you're on the East Coast, I think you're heading into a long weekend. Lovely to see you. Okay, so I have a mere 8 minutes before I actually have to hop on a meeting. So I thought I'd jump on here and do just a couple of quick questions. I did actually have a question posted, DM to me from Olivia Swan. So hopefully she can watch this from the UK. Hello, Olivia. She's asked me the question, what can be done about women who have premature ovarian insufficiency in their 30s, aside from egg donation treatment? That's such a difficult question, I must say. And to those of you who don't know, premature ovarian insufficiency is when the ovaries kind of stop working earlier than they should. So we know menopause is pretty much when the ovaries run out of eggs, even though at menopause there's probably about 1,000 follicles left. Early menopause is before the age of 45. Premature menopause is the age below the age of 40 and affects about 1%. And that's the group that we talk about, premature ovarian insufficiency. So it's really important to understand that about 50% of the time we don't find a cause. And there's definitely a cause, and it's probably genetic, but the list of causes is about as long as my arm. And so we don't go looking for that needle in a haystack, particularly as it doesn't cause any other health ramifications except for fragile X premutation. We know that women who have premature ovarian insufficiency and fragile X premutation do have some health issues, particularly around ataxic gait. So it is something that's worth looking for, and does actually also affect the offspring. So that is one gene condition we go looking for. We also go looking for autoimmune causes such as thyroid disease, type 1 diabetes, and something called Addison's disease, which is an autoimmune disease of the adrenal glands, which can be life-threatening. So just by way of explanation, the eggs are kind of lost either because they were never there to begin with, or they are destroyed by an autoimmune process. And so generally speaking, women who have premature ovarian insufficiency kind of don't have many eggs left, if any, and it's extremely hard to stimulate them. So you could, if they are still having the occasional cycle, you can track and do a natural cycle IVF. But generally speaking, if there are no further periods, then it's extremely hard to do this because the ovaries just won't respond. There are experimental treatments, things like injecting platelet-rich plasma into the ovary. There's some work being done in that space. Again, it is all completely experimental. There is no good solid data around this. And is it actually the injection of this platelet-rich plasma, which kind of attracts in all of these growth cytokines, or is it actually the physical act of agitating the ovarian tissue and therefore it responds? There is a group out of Japan who has looked at something called ovarian activation. So again, they're kind of chopping up little bits of ovary and injecting it back into the ovary itself in the hope that it kind of stimulates the ovary to actually respond. And there have been babies born from that. And that's working on the premise that there are still a few thousand follicles left. And if you are young, then the quality of those should be good. So none of these are considered standard treatment. They are all experimental. They are mostly in centres being done using experimental protocols. We don't know the long-term ramifications of this on children born of this kind of treatment. But I understand that when you are hopeful and when you are really, you'll turn over every stone, then these are techniques that you will look at. But egg donation treatment is our standard of care and works really, really well. And there's been many a live birth from egg donation treatment. And there's really good research to show that the bonding with a child born from egg donation treatment is exactly the same. You've spent 9 months growing this baby. So the epigenetics of the environment that you create for this baby is just as impactful on its long-term health outcome as the genetics that it carries. In fact, the bond is strongest by you giving birth, you breastfeeding it, you waking up during the night. All of those things create a much stronger bond with a child. So, at the moment, although there is no doubt research on the horizon, the standard of care for premature ovarian insufficiency in the 30s is egg donation treatment. Life of Brit, can follicles have more than one mature egg in them? No, they can't, but sometimes we go through more than one follicle at the same time, and so it might look like we've collected 2 eggs, but actually we've gone through 2 follicles, or we've aspirated from the follicle before, not found an egg, and then it just so happens that the egg is sitting in the tube when you go into the next follicle and aspirate it, and so voila, you end up with what appears to be 2 eggs. Rach Perry Pilates, how are you, my friend? What's the minimum size of follicle that could house a mature egg? Okay, this is kind of averages, right? So the minimum size, I would say about 14 millimeters. Of course, you can get follicles that are measured. Remember, measurement is based on an operator, so sometimes measurements can be slightly inaccurate. But we would aim to get mature eggs out of a follicle that is greater than 14 millimeters. Life of Brit, chances of an embryo transfer being successful on the first try. For every blastocyst, so expanded culture, embryo that is transferred, it has a pregnancy rate attached to it. And in most centres, again, it depends on the age of the person, if there's any other pathology such as endometriosis, it is around, I want to say 35-40%. But it will be higher or lower depending on the couple, the age of the eggs, the quality of the embryos, what other pathologies might be going on. So I think that it's really difficult to give you an exact answer on that. Oh, I'm going to answer one more question. I have 1 more minute. Zoe Harris, how often would you suggest someone who has endometriosis and is undergoing IVF have surgery to remove growth? Once. Once, Zoe. Now, you will sit 6 gynecologists around a table and everyone will have a slightly different opinion, but that is my opinion. Do it once and do it well, and if that endometriosis happens to come back, it would be worth considering medical suppression of that endometriosis. Or if you have severe disease, if you are talking about fertility, the evidence says to us that moderate to severe disease, so say stage 3, stage 4 disease, is not best managed by surgery. It is best management by creation of embryos, suppression of the disease using medication, medical treatment for about a 3-month period of time. It's a little bit vague there. And then putting the embryo back into a medically suppressed environment. That is considered the best option. If you have minimal disease, which obviously you're going to diagnose on a laparoscopy, then the resection of that minimal, or treatment rather, of that minimal disease will give you about 6 months. We don't recommend continuing to resect disease. It is not right for the patient. It creates more scar tissue, more pain, more risk of complications, and it is not going to improve your IVF outcomes. Oh, I think I'm going to leave it there, Groovers. That's great. We knocked out half a dozen questions there in a short period of time. Have an awesome rest of your week. I'm still on track for next Tuesday night to have a guest on live. I do remember Life of Brit. I remember you put your hand up. So it may be you, but we're going to have one of our viewers on live onto our Instagram Tuesday night for a little interview. So it could be you. Have a beautiful week. Ugh, I can't talk tonight. Have a beautiful week. The rest of you, enjoy your long weekend if you're coming into it. I'll see you next week. Bye.